Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey friends, thanks for joining me this week and for downloading this week's episode. Today, I am speaking with physical therapist Zachary Stearns about how to screen for psychological factors when treating patients with chronic pain. Zachary is a physical therapist in Durham, North Carolina. He's board certified in orthopedic physical therapy and has worked in outpatient clinics which have a focus on musculoskeletal pain management. He's currently working on a large research study, which is called the AIM Back program. It is a collaborative effort between Duke University and the U.S. Department of Veterans Affairs. He's also a PhD student in health sciences. On today's episode, we discuss the benefits of screening for psychological factors, or what we call yellow flags, in chronic pain management. What types of screening tools can you use? So self-report measures that you can use in your practice. As physical medicine professionals, should we be screening for suicidality? And if we do have a positive screen, how do we approach that? And how do we follow through with that? And then finally, the barriers to implementing and screening psychological factors in clinical practice. I want to thank Zachary for joining me on this week's episode of the Healing Pain Podcast. If you're a clinician, this is a really content-rich episode where we really kind of go deep into how to screen for psychological factors, which are really important. We also touch on that topic of suicidality. We have a little bit of not controversy, but a little bit of a healthy discussion, I would say, on should we be screening for suicide and what do we do after we screen for suicide. Zachary also just finished writing a paper in the Journal of Orthopedic and Sports Physical Therapy. I do mention that in the beginning of the episode. It's great if you kind of read that paper and listen along with this, or maybe listen to the episode first and then go check that paper out. It's really useful and I think it'll really help you. Okay, without further ado, let's begin and let's meet physical therapist Zachary Stearns. Hey there, Zachary. Thanks for joining me this week on this episode.
Thank you, Joe. I'm happy to be here.
I came across the paper. I want to make sure I mention the paper you lead authored or co-authored with some other PTs. It's really an important topic. It's called Screening for Yellow Flags in Orthopedic Physical Therapy, a clinical framework, Journal of Orthopedic and Sports PT. So it's kind of going to help frame our little chat here today. And of course, I encourage people to go and read the paper, especially if you're a clinician and you're learning how to screen for yellow flags. I enjoyed the paper. I mean, it's a short, concise paper, but I think it's pretty powerful. So thanks for your work there. Tell us how the idea for this paper came about.
Yes, thank you, Joe. I appreciate that. And as far as this paper came about, it really came from this network and this really energy between me, Marissa Carvalho, and Trevor Lentz at Duke University, and our colleague Jason Benachek at the University of Florida. All of us are extremely in favor of incorporating assessment of psychological factors in physical therapy practice. We're on board with using a standard tool. For us, it's we can talk about it more later, is the OSPRA YF, but it's certainly not the only tool around. The whole point was that we've noticed so much resistance from clinicians, and this isn't just in physical therapy, it's really throughout healthcare, resistance to this idea of having some type of psychological assessment for pain, as well as just incorporating psychological approaches for pain management, for treating pain, for helping those who are living with pain. And there's so many factors that lead to that sort of hesitation or reluctance to using these type of strategies. But really one of the biggest ones is just not knowing what it looks like, not knowing what to do, and not knowing how to incorporate it in their clinical practice. So we all agreed that if we could just outline some type of framework, some type of process that is adaptive, that can be adapted to different clinical settings and different patient populations, but actually has some concrete guidance about what we recommend and how to really improve our management for those living with pain.
It's a great way to start. I mean, I think right now we're almost at this watershed moment where everyone in the PT profession, or almost everyone, is aware of the psychological factors that are associated with pain as well as physical function. I don't want to leave function out of there and just talk about pain. So high awareness, but as you mentioned, the behavior to screen for it in clinical practice is Probably not there yet, right? And the behavior, the professional behavior varies widely depending on what year you graduated school, where you work. If you're working as a solo PT or an interprofessional team, it's kind of a really big mixed bag, right?
Mm-hmm. Absolutely, it really is. And there's already so much research, and there's so many decades of work, and really it's been known for really over a century, the role of psychological approaches, and the biopsychosocial model is not new, but we're at a point where for people like me who are younger clinicians, we've certainly been trained about the importance of the biopsychosocial model. We've been trained about the importance of looking beyond just the anatomy, just beyond the actual physical processes, and realize that we all live in a context. Part of that context is what we think, what we feel, what we care about, what we dream about, what we want in our healthcare, and also our social context of where we live, who do we live with, what are our relationships like. All of these things are so crucial. And like you said, we're in this, I totally agree that this is a watershed moment in which there is so much general awareness about the importance of these. But now, what do we do? How do we actually go about incorporating this knowledge in order to transform our practice, really, hopefully for the sake of making it better? And that's exactly the energy behind these ideas.
People typically will do things, or they'll continue to do things if they feel it's beneficial. So when you ask, especially for seasoned professionals that have been practicing the same way, to have a seasoned professional change their practice skills, change their behavior can be tough. There's actually been lots of studies on that, especially in the realm of like prescribing medication. It's hard for physicians to change their prescribing habits. So, reflecting on our behaviors as PTs and other professionals, it can be difficult for us to change our behaviors. What's the benefit for a PT or another professional in the clinic to start to screen for psychological factors?
Absolutely. Great question. And I'm so aware of how hard it is to change, not just for seeing other clinicians, but also myself. We need to, when we incorporate new evidence, when we think about, okay, we want to improve our practice and therefore change our habits, especially because as clinicians, we want things to be easy. And sometimes the easiest thing is to do the same thing over and over again. It's easy for us. Now, here's the thing. We want to have the best outcomes for people. And I think that the biggest benefit is this idea of thinking about those people we've worked with. And even though we really want them to feel better, they want to feel better, things are not improving. What is it that led that outcome to happen? And then what can we do to actually improve that outcome? And so the argument really is that to be aware that there are these other factors that are important. And like you said earlier, it's not just about pain, but also about really functioning and what we do. Because for many people tell me about how if they could just do these things even with some pain, that would totally be success for them. Mm-hmm. It's not about pain going all the way away for many people. Of course, for many people, it's about making their severe pain less severe. But when we realize that the outcomes for a lot of treatments that have been pretty traditional, some medications, some invasive treatments, not seeing the outcomes. Just thinking about how many people I've worked with who said they felt worse after their surgery. Mm-hmm. Now, if this surgery is meant to be this definitive treatment, why is it that someone with knee osteoarthritis, severe knee osteoarthritis, then felt worse after their surgery? What do we do about that? And that's really the argument to make is, what if we can make some changes so that this doesn't happen, so that people actually feel better? And realizing that if there are some factors that can be addressed and modifiable, then what if we work to modify those? And that's the whole reason for really focusing on some of these more psychological factors, what we think about movement, what we think about pain, how we cope with pain, how we manage it, and maybe anxiety, depressive symptoms. These are things that are modifiable. So that it's just a logical step to say, if these things are modifiable, then we think about what can we do? And if we're at a spot where we don't have the expertise to do this, then how do we make sure that this person in front of us living with pain does work with someone who can help to modify it?
As we talk about this, I'm just reflecting back on some of the training I've done with practitioners around this topic. There's a little bit of it's a hesitancy to go into this. There's a bit of an imposter syndrome. especially for PTs, because they're shifting from that biomedical to a biopsychosocial, spiritual, however you want to look at that. How do patients respond to this? How do you find patients respond when you first start to talk about psychological factors associated with their challenges, and where are you starting to have that conversation?
Mm-hmm. This is so important. And I would argue this is way more important than what clinicians think, because it's really, if we start to talk about these topics in a way that's not so great, patients can feel stigmatized. And the topic is really can be very stigmatizing for lots of reasons. And I think it really comes down to patients want to be trusted and believed when they say, I'm feeling pain. And pain is invisible. So this is the hard thing, is some injuries are visible, but the actual experience of pain is not so visible. So when we start to ask some of these questions that are a little bit more psychological in nature, or even use the word psychology, this can trigger a really, really tough moment and really tense moment between the clinician and the patient, because it might sound as if the clinician is doubting the reality of pain, doubting that the pain is physical, or that it's even real. And that is one of the biggest struggles for me, because to me, I believe we must absolutely trust what the patient is telling us, that if they're experiencing pain, then they're experiencing pain. What we want to do is we want to make sure we're not missing anything that could be getting in the way of their recovery, or getting in the way of them pursuing a more meaningful and more fulfilling life for them. And that's what some of these factors can do. If we feel like I'm not going to do anything that could make my pain worse. Exercise, activity, going out with my family, I'm afraid that's going to make my pain worse, so I'm going to stop and do nothing. That's what we're talking about, is something that could get in the way of living their best life. So we just need to talk about it in a way that we say that we just don't want to miss anything, and that therefore, with more information about what you're thinking, what you're feeling, that can make sure that we amplify our care in the best way possible, and making sure that we're doing the best thing for you personally. And when we talk about it in that context, where it's not like we're investigating, or not we're testing, or almost just trying to see like what's going on mentally, but saying we want to provide the best personalized care for you, this is where patients tend to be much happier with it. They want to know that they're being heard and listened and trusted. And so as long as we frame it that way, and not like, okay, your image looks fine, therefore I think it's psychological. What's the psychological factors? That's where clinicians get into big trouble. Mm-hmm. And so that's absolutely not the intention of this type of process. It's really meant to be a process that makes sure we see all of the relevant modifiable factors, so that we can do the best treatment plan for you personally.
And I just want to take a moment to clarify, and correct me if I'm wrong, in your framework and the way we should approach this, is we should be screening. So when people hear the word screening, they understand what a screen is, but we should be screening during the initial evaluation or during the assessment. Because oftentimes what newer therapists, or therapists who are just coming into the psychologically informed care approaches, is they'll do a traditional, evaluation, and then they'll only screen maybe 8 or 9 weeks later, when they find that, this person's not having such a great outcome here. They're not really progressing. So let me screen now. And I think that's even more jarring for someone, because now they say, oh, now you're asking me about factors related to fear and anxiety and depression and emotions, et cetera, et cetera, et cetera. And they're shocked. Doesn't go so well. Then the patient feels stigmatized. So screening happens day one with every patient.
Mm-hmm. I'm so glad that you mentioned that. And this is, I think, still going to be, I'm not sure if controversial is too strong of a word, but the way that you outlined that process that I think some clinicians do, it is very troublesome to not screen day one, and we're not getting the outcome we want. So then what else could it be? It's very troubling. And what we actually see it is more like, it's more like red flag screening, in the sense that a screen is meant to be, we screen maybe everyone to make sure that we're not missing something from the beginning. In the same way that it's pretty standard for many clinicians. I mean, think about how many times we go to a visit and we answer what seems like 1,000 questions before we even see someone, because part of that is that screen of making sure that we're not missing any of these big deal signs or symptoms from day one. And we see it more like that, especially considering that for many of these factors, clinicians don't seem to be very good at just guessing it. Even though we like to think that we're really good at guessing, say how much someone avoids activity or even their depression, we're really not. The evidence isn't there that clinicians are very effective at just guessing that. And that's the reason for screening it in the same way that we're probably not so good at guessing some of certain red flag symptoms. That's why we ask them to screen, to make sure we pick something that's sensitive. And if it's no, then okay, we move on. But we get into trouble if we don't screen from the beginning with some of these factors and then look at it later, because there are going to be many people who don't see that improvement in their outcome. And so that to then screen later, it's not so good, especially because the stigma there of saying, okay, you're saying it's in my head the whole time, and that's why I'm not getting better. And that's just not going to be the best way to go about it.
So as professionals, we're aware of the psychological factors, but we're aware of the factors and we think we're good at identifying them. It's kind of like asking a professional, do you think you have a good therapeutic alliance with your patients? Everyone says yes. Right?
Yes.
It's like, do you think you can identify depression in your patients or anxiety or fear avoidance? Everyone says, oh, sure. Yeah, I see that every day. But the truth is, no, use a psychometric tool to screen for it, basically. So now that we've piqued everyone's interest and they're going to start to screen with every patient pretty much, especially, every chronic pain patient, I would say, if not every patient. What's your favorite tool?
That's a great question. For me, in my practice, it has been the OSPRA-YF, and there are a few different reasons for it. So the OSPRA-YF, it stands for the Optimal Screening for Prediction of Referral and Outcome Yellow Flag Tool. So there are other tools out there, and there's so many questionnaires. What I like about it is really that there are three essential things. One is that when the research that's been done on it has been in a general musculoskeletal pain population. So it's not specific to one body area, which for me in my clinical practice has been very important because my practice has not been in one specific body region. And the second thing, it's been in a general adult population. Again, that fits with my clinical practice. And then the third is that it's multidimensional. So this multidimensional aspect is, in other words, there are many different factors, and as opposed to many questionnaires out there that are really just one factor. And so I've seen, for example, clinicians will use a measure on like fear of movement, the Tampa scale of kinesiophobia, and that's like their analog for screening, psychology. And so that's something that it's important, but we want to be in a spot where if we're going to screen, we want to have the biggest bang for our buck in the fewest questions possible. So that's the whole point of the OSPROs. It's meant to estimate scores for 11 different psychological factors, including positive ones. So this is crucial because I'm certainly of the opinion that we're focusing so much on the negative things and not enough on the positive things. Mm-hmm. And this questionnaire does incorporate positive factors, self-efficacy, pain acceptance, self-efficacy for rehabilitation. And so this is really crucial because we're looking at many factors, in negative and positive.
And people are going to want to know, okay, what does it look like? How many questions is it? How long does it take? Time management and ease to integrate this into an assessment or an evaluation process is really important.
So there are three different versions. There are three different versions. There's a 7-item, a 10-item, and a 17-item. Many of the studies have suggested that the 10-item is this happy medium that we'd expect, and it's nice if it's on one page. The scoring of it's different from other measures because it's meant to estimate all these questionnaires. It's not like you add up the number. It's that you need an answer for every question so that it can estimate how people score on these questionnaires. So you do need all 10 answers. And what's nice is we work to integrate it with our electronic medical record, so we can actually ask it within the visit, or if they were to complete it, ahead of time, whether it did electronically or on paper, we're able to just populate the scores and really use it like it's intended. You see the screen even before we see someone, we see how someone scores on these. So that's a big benefit of it. And with it being 10 questions, it can be done, very, very quickly.
And is it is there a measure of statistical significance with that, or is it more like a qualitative, just seeing how someone's progressing throughout their plan of care?
Also, great question, because again, unlike some of the legacy questionnaires that have the sum score, it's not designed to be able to sort of see this change. And this is where another reason why it's a little bit more analogous to red flag screening, where we don't think about minimal detectable change or minimal clinically important difference for red flags. Similarly for this questionnaire, we use it as a screen initially, and then we can certainly follow up down the road as monitoring the response to treatment, monitoring some of these factors that can inform our decision making, but not in the same type of quantitative aspect. There is a quantitative summary score that's used in research, and some clinicians can use it as well. But the way that most clinicians, I think, use it is that it estimates whether or not someone has this yellow flag based on whether or not they're in the top quartile. Are they 75 percentile or above for the negative factors, or in the bottom quartile, 25 percentile or below in the positive factors? And therefore, it has the output of yes or no. Do they screen positive for this psychological factor, for this yellow flag? And so therefore, it's more of the screen. Do they screen positive or negative for that to inform our decision making afterwards?
It's what I use in practice. I find it to be really easy. And I like that there's not a number that I'm looking for as far as a significant change. Some professionals have a hard time with that. They want to be able to measure things specifically. I like the idea of it being, a little bit more loose and flexible. And again, just being that screen where, hey, this could be a trigger for a referral, for example,
exactly,
to a mental health professional or to another professional. With that in mind, you have a pretty good kind of step-by-step framework in this paper. There's 4 phases to it, which I think are important for people to become aware of. Can you talk us through those 4 phases? It starts with kind of just a standard physical therapy screen.
Mm-hmm. Yes, absolutely. So we start with a standard screen. This is where ideally there's a screen either before the evaluation itself or during the evaluation. And then from that initial screen, again, can look different based on what setting you're in. And then from there, then we engage in shared decision-making with the patient. Now, this is really so important to me because we need to make sure that the patient is on board with our plan and then it thinks it's a good idea. And that does include sort of giving a rationale for asking these questions that we've talked about before is the importance of framing it in a way that we just want to make sure we get a glimpse of everything that we need to know to make this the best treatment possible. And then from there, the shared decision-making aspect can, what we think, lead to 4 general pathways. One pathway, standard physical therapy, it's hard to define that, but really what we mean is that we certainly know that exercise and physical activity is very helpful for those with musculoskeletal pain. We certainly know that there are specific exercises out there, and as well as general exercise that's very helpful. We know that a multimodal approach that incorporates exercise and manual therapy is worth considering. And above all, we know that self-management is so crucial for those with pain, particularly with musculoskeletal pain. And so therefore, for many people, we don't necessarily need to incorporate some different psychological interventions in our practice. And so therefore, if someone were to present with, no positive screens in the OSPRO yellow flag tool, then we would say we don't need to necessarily move forward with progressive muscle relaxation or activity rest cycling, these other psychological skills. But for some people, if they were to screen positive, then we can consider one of a few different pathways. And these other 3 pathways, there's either a more psychologically informed physical therapy practice in which we use some different psychological skills or interventions. And then another pathway is doing that psychologically informed physical therapy, but also considering a referral, particularly for someone who presents with signs or symptoms of mental illness, in which case we say, I, as a physical therapist, am not the expert to treat clinical depression or an anxiety disorder. And therefore, we want to expand the team around the patient to make sure that we have professionals who specialize in treating their own respective conditions, their own respective specialties. And then that last category being immediate referral for someone who's in either a suicidal crisis or something that's very, very severe and needs immediate intervention. And then the final step is really an ongoing step of treatment monitoring, in which case as 2 weeks go by, as 4 weeks go by, we're reconsidering how things are going, not just in terms of range of motion or strength or physical or endurance, but also in terms of the psychosocial profile of how someone is thinking or feeling or acting in their context, living with pain. And then that can therefore go back to inform our shared decision-making moving forward.
Excellent. So I just want to kind of frame this out for people because they're not looking at the paper necessarily, but that the 4 steps are like standard physical therapy, step 1, PIPT, step 2, PIPT with referral, step 3, and then immediate referral, kind of step 4. And I don't mean to say step as like a stepwise, but it's a conceptual model to help you make some decisions in practice. There's 2 important distinctions here, which I think is worth talking about. So PIPT, which stands for psychologically informed physical therapy, or we can just shorten it to psychologically informed care. The first one there is the PT does not refer out. They just realize that there are psychological factors and they have to bring in some type of cognitive behavioral techniques with their traditional PT treatment. And there's a ton of cognitive behavioral techniques that practitioners can use that are evidence-based. The second one is psychologically informed care with referral. So I just want to make what you did is I think is really brilliant actually, because people hear that, well, if someone screens high for, let's say, depression, that I should stop treating them and they should be referred out to a mental health professional. And really what you're saying here, which I really appreciate, is no, we continue to care for them because what we do as PTs actually has a very positive impact on their depression. But we also need someone else here to kind of help this whole process along because this person is high on the depression scale, let's say.
Absolutely. And I'm so glad that you mentioned that because that is an instinct that many physical therapists will have. And I'm sure many clinicians in other specialties too, is once depression is seen as something as I need to refer out. So many people feel like they're this ping pong ball going back and forth from provider to provider. And that they're not actually receiving care. And so think about how many people might be living with pain and depression, and really with chronic pain, it's most people live with depression at some point with chronic pain. And so think about this experience of you have pain, you go to physical therapist, you have depression, you really need to get that taken care of before we can do anything. You need to go to a mental health provider. Mental health provider says you have pain, you need to go see physical therapy. And so in reality, we are treating whole people with what is really a normal response. I mean, you live with debilitating pain. I mean, if you're asking someone not to feel down about that, that's a lot to ask. So in reality, depression is not a contraindication for physical therapy, for musculoskeletal rehabilitation. What we just need to make sure is that we are staying in our lane. And we're also making sure that we have the best possible team of providers working with this patient. So, for me, and then to go back to, well, what about times where we don't refer? It's really that there are some factors that are not depression that are considered psychological factors, which are not mental illness. If someone is avoiding physical activity, that's not mental illness. And that's not something that we would need to refer at. And therefore, that's when we think about strategies that we can use in physical therapy practice that are meant to help with that situation.
Yeah, it's mental health physical therapy is a strong interest of mine. And when we look at just the United States of America, there are probably about 60 million Americans who struggle with some type of mental illness. And most of them are somewhere in the healthcare system. And there's a bidirectional relationship between poor mental health and poor physical health. So they're in our clinic. If we started referring every single person out that had a yellow flag, one, we probably would overwhelm the already overwhelmed mental health system. And 2, it's not really good for our professional stance, I would say. And realizing, I think one of the reasons I was so excited to talk to you is I think what your paper does, if people really take the time to read into it, is they realize, wow, I as a PT have a really big role in helping someone with whatever mental health struggle they're having, basically. And I think that's really important. So I appreciate that. The immediate referral column, which is kind of like the red column, right? The flashing red light, the red flag, if you will. Talk to me about that, because there's something in your paper, because you give kind of like you give some case examples, which is great. And there's a case example there. Immediate referral, the physical therapist should call 911 and wait till emergency services arrive to transport them to the emergency room. Can you talk to us about that?
Sure. Yes. Thanks so much. And this is really important to touch base about, because this certainly happened to a colleague of mine, actually, Marissa Carvalho, who is one of the co-authors on the paper. And she and I agreed that this is not going to happen very often, but I think it's just a matter of time for everyone at some point, if they're in a situation where they practice with those living with pain and living with severe pain, and many other situations as well. And not just about pain, is that you might be the provider who is working with someone just at a crisis moment, in which case, especially if you're in a setting where I just went to my doctor, they said there's nothing they can do, so they're sending me to physical therapy. And so then this is potentially a breakdown moment for someone coming to see a physical therapist to say this is, and so if someone's has active suicidal ideation, certainly if they have plans for suicide. And I do think it's important to be comfortable asking this question if they're flagging, say the flag OSPRO. And then if we have some other depression screening process, they're flagging that as well. This is where it's our responsibility to make sure that we are, that we know how to handle a crisis moment. And this.
So when you say, you said it's important to ask the question. So what is the question? Because there's one key question that we should be asking someone if we think suicidality is a problem. What is that question in your opinion?
Sure. I usually will have two. One is, have you had thoughts about harming yourself or harming someone else? And then, yes, do you have an active plan for harming yourself?
Right. So do you have thoughts and do you have a plan, basically? They're two simple questions. They don't take more than 30 seconds, probably.
Exactly right. They don't take more than 30 seconds. And anytime I've asked that, I've always been glad I asked that, because someone's like, no, I assure you no. And then if someone says yes, though, then what do we do? And that's where we need to actually work with our organization. What's the plan? What's our crisis plan? And have like a standard operating procedure for that, because that's going to depend on are you already in a hospital? Are you in a private practice? Are you in someone's home? This is going to be so different based on your setting. Fortunately for us, when at our pain clinic, we worked with psychologists, and that was our process of, we're going to bring in a psychologist right now and determine, is this a 911 call where someone is an immediate threat? If they leave this building, they will harm themselves. We need to be prepared for that. And so that is, and there's of course a 24/7 suicide hotline in America, and this is going to be available in many countries. So just knowing what that is and making sure people are aware of that as well is another option, for those who don't have suicidal ideation, but, may have signs of depression and they're already working with a provider. It's something to be aware of. But certainly working with your own organization and being aware of the questions to ask, and then what to do if someone were to say, yes, I do have plans.
Right. So different organizations, different practice settings can create their own plan if in fact you come across that challenge. Mm-hmm. Yeah. It's interesting because I appreciate you putting that in the paper, because it's forward thinking. And one, it requires a professional to feel safe to have that conversation and to be brave. I mean, this is a brave conversation to have with someone if you're not used to having the conversations, but they're really important within the chronic pain population because suicidality rates are higher there. There's also some controversy, though, about how to handle a patient when they're in that position. So some people say, yes, call 911 right away. And there are also other mental health professionals that say not to do that, actually, that there are challenges that have happened with that. And I've come across these both within my own patients as well as just speaking with other mental health providers. Some of the challenges are that the person winds up in the emergency room and their care is not handled properly. They feel stigmatized. They're placed into a long-term psychiatric, ward and placed on, heavy doses of medication. So they're in the mental health community itself. If you talk to psychologists, there's not a clear way to necessarily handle it. I think it's important to mention that. So practitioners don't necessarily feel like calling 911 is the only option. You mentioned a hotline. You mentioned if you're in a setting, you can call someone into the clinic. Lots of different options, right?
Mm-hmm. Absolutely. And I'm really glad that you mentioned it, because these are one of those clinical decisions where it's hard to know what the right decision is in that moment. And as I think anyone who's a clinician has either been in that moment or they've been with another clinician who was in that moment of like, I don't have a good feeling here. We need to do something. And, you're right. We need to be considerate of what are the consequences on someone's life potentially. And it actually depends what state you're in, right? There are different rules depending on your state about what happens in that situation. And, even before I was a physical therapist, I actually worked at a psychiatric hospital for kids. And I actually saw the consequences of some of these situations in which someone's unfortunately in a tough spot, and then their life is turned upside down for a period of time. So we absolutely, therefore we need to take it, very seriously, not just, call 911 and anyone says that they're, really, really sad. That's like not what we want to do, but we need to work within our organization and actually have this conversation. I mean, we just need to talk about what to do and what makes the most sense, especially, given that we're all in different parts of the country, we're in different organizations, work with our, colleagues who are in mental health, behavioral health, of what do they recommend, given that we're, in a similar context.
Yeah, it's interesting. I've talked to a couple of colleagues of mine who are psychologists, and they've actually shared papers with me that even well-qualified mental health professionals at times have a hard time screening properly and knowing exactly what to do. And let's not forget there's some liability there, right? So if you're screening for something and you potentially make the wrong decision, in PT, the liability factor is extremely small, but probably more so for the mental health professional, because that's that is their scope of practice, so to speak. As we're talking about other professionals, what do other professionals think of kind of this framework that you've created and laid out, and the idea of PT screening for psychological factors?
I'd love to say that everyone loves this idea and everyone wants to do it, and everyone I've talked to, it's just changed their life. And in reality, it's not the case. I mean, there's so much inertia around so much in any specialty, but part of our inertia in physical therapy is training. It's not, for many people, this is not part of their training, any of it. Screening psychological factors, doing psychological treatments, even collaborating with mental health providers, it's not part of it. So the reality is I think for clinicians, we, in the same way that, here I am talking about how we need to meet patients where they are, we need to meet clinicians where they are and see is this something that interests them, maybe engage in a little, planning about, is this something that you'd like to incorporate? And if so, what are the barriers, and navigate that? For some people, it's using what tool it is. I think the big challenge is just almost the philosophy, and this is where this biopsychosocial versus biomedical, debate, which, I've seen a lot of people actually talking about moving beyond, the biopsychosocial model, but for many people, we're still not beyond the biomedical model of saying that it's really just about what's going on physically in someone's body. And even for those who really care about psychological factors, who care about trying to incorporate psychologically informed physical therapy, there's one thing I hear so much. And so I call it the can of worms problem, which is that if we ask about this, many clinicians feel like they're opening a can of worms. And that ultimately comes down to, I think, some healthy fear of what do I do when these things come up. And so the point is that, yes, a lot of skills should be developed if we're going to incorporate this framework, a skill of actually talking about these factors, a skill of engaging in decision-making, a skill of actually assessing using a tool, using a measure, and then a skill of using psychological approaches, and a skill of collaborating with clinicians. I mean, there's a lot in that. So that is what is essentially the can of worms problem of what do we do now. So therefore, I certainly hope that there continues to be development in terms of entry-level education, continuing education, that can help build confidence for clinicians in that department. But there are some who are sort of like, yes, this is kind of putting words on stuff that I already wanted to do anyway. And so it's cool to see that a lot of clinicians are kind of acting in parallel, like kind of incorporating this. And you mentioned this too, using the OSPRO, that a lot of people are acting in parallel of kind of doing this already. And so therefore it's really powerful to be in a spot where you can see this in print and be able to say, okay, here's a framework to consider. And hopefully, it can be part of ongoing training and development for future clinicians.
Yeah, the OSPRO and the Chronic Pain Acceptance Questionnaire are the two big ones I use. And there are other ones, but those two are just standard, and it gives me a lot of great information to work with people. So we talked a little bit about barriers. Are there any other barriers to, we talked about a little bit of time management, which tool, implementation. There's obviously some education here that's required of the professional. Any other barriers that you see with screening?
Absolutely. A big one that comes up is evidence, and this is where I think that if we say, here's the evidence that these factors are important, great. And we're kind of at that point where, okay, there's evidence that these factors are important. And so the evidence of what to do about it really needs to be bolstered. We need to have some convincing evidence. And part of the reason that this paper is the way that it is it's certainly my hope that we can put some of these thoughts to the test. Is taking an approach like this, which is a little standardized, but it's not completely rigid. It's not very rigid, but there's kind of a conceptual ideas. Does that actually make a difference? Does that help? I hope that it does. For me, I feel like it does. But is that, if we were to implement that in a bigger scale, would that actually make a difference? We need evidence that would be a meaningful way of going about it. Because so long as there's not this convincing evidence that you should do this, there's going to be a clinician who's reluctant to say, well, there's no evidence that this is better for me to do, so I'm just going to go about my own way. That's the inertia there. And I hear that, and I think that makes a lot of sense. So that leads to the other barriers. There really needs to be consensus all the way up and down this vertical line for healthcare organizations, for the clinician, the administrators. Everything. That there needs to be some consensus that this is the right way to go about it. But certainly I would hope that the concepts there are meaningful, like just actually talking about some of these factors to make sure that we're doing what we can to help everyone. And so that collaboration between different professionals and different people within an organization is a significant barrier. And so that I think we're seeing more and more improvement there. More and more specialties are working together in different projects. And so I'm hoping that can continue to improve. But yeah, so therefore, like evidence and then collaboration are really significant barriers that I perceive.
Well, those of us who follow the podcast here appreciate this and think it's actually a big leap forward, not just a step. It's nice to see this in a journal in a way that's succinct and useful. And you provide a couple different screening tools. I believe there's two in there that practitioners can use in practice. And of course, if you're interested, make sure you check out the paper. It's in the September 2021 Journal of Orthopedic Physical Therapy. It's a clinical commentary, and it's called Screening for Yellow Flags in Orthopedic Physical Therapy, a Clinical Framework. Zachary, it's been great having you on the podcast today. Please let everyone know how they can learn more about you and follow your work.
Sure. Thanks, Joe. I've really appreciated it. And it's really an honor, especially considering just you've interviewed some of the most amazing heroes of mine. So it's really just an honor to be a part of this interview. And for me, you can find me on Twitter. So I'm at Zachary Stearns is my Twitter handle. And so, yeah, I'm happy to answer questions or engage with anyone on Twitter.
Great. So of course you can reach out to Zach. He's at Zach R. Stearns. You can reach him on Twitter. For me, take a screenshot of this episode and you can tag me on Instagram. It's at Dr. Joe Tatta. And at the end of every podcast, I ask you to share this information with your friends, family, and colleagues on social media, Facebook, LinkedIn, Twitter, anywhere where people are talking about psychological factors with regard to chronic pain. We'll see you next week. Thanks for joining us.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit integrative pain science institute.com. That's integrative, Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.